So I'm going to launch into the RSV bronchiolitis just sort of as an overview and how that relates to it, okay? I will say, we're kind of hoping to go back to the committee because you guys have been so successful in helping us work with this piece of equipment and saying, if we have somebody come in here and they have a work of breathing and they have an FiO2 requirement, why are we going to hold this from them? I feel like we could go there with other patients and just not be bronchiolitis. Or, yes, they have bronchiolitis, just write it in the note, right? Simple as that. Okay, so to start with, RSV, right? It's the most common cause of a lower respiratory tract infection in kids who are younger than 1 year old. So it's estimated that up to 172,000 pediatric hospitalizations occur in kids who are less than 5 years old. So the outbreaks for RSV are seasonal. This year kind of blew us out of the water. I'm sure that you guys see the residual of that, right? When this came up, what happened was the ED and the PICU were like, holy cow, we are getting a lot of kids in here, right? And we can't hold these kids down in the ED and wait for a PICU room to become available. And PICU is sort of like, I don't really want a high flow kid. They use it as a stepping stone. Somebody was intubated, then they went to CPAP, then they are down to high flow. Maybe they do or they don't need to be on high flow, but they might just be supporting them on high flow while they get their feeds up and running, right? And so PICU was sort of like, help us out. And so where was the next best place? And that was with you guys. So these seasonal outbreaks, they tend to occur between November and April. This data suggests that the peak was between January and February. March is like our explosion month. And if we look back at all the data from last year, it was a pretty bad one, right? And we never know how it's going to be year to year. So what will RSV lead to, right? It'll lead to lower respiratory tract infections, bronchospasms, pneumonia, acute respiratory failure, and then the big guy at the bottom, bronchiolitis, right? Just so everybody knows, bronchiolitis can occur in everybody, right? This is not just those kids under 5. We're not just hospitalizing those kids under 1. We as adults could actually get this, right? For us, it might just be cold symptoms, a runny nose, all that fun stuff. That's not the case in these little guys. I'm going to throw out some numbers for you. By the age of 2, more than 1/3 of children have experienced bronchiolitis. About 10% of those are hospitalized. 16% who are hospitalized are less than 2 years old. This can just go on. There's a ton of these, right? But hospital costs, and this information came from 2009, are estimated at about 1.73 billion for our nation, right? And then I just had to throw that bad guy down because people are like million, billion, whatever. The comparison between a million and a billionaire, right? A million seconds it takes you about 12 days if anybody wants to volunteer to count that out, right? A billion seconds takes about 31 years to count that out. So if this number were 1.73 million, we might be like, a billion, kind of a big deal. Make sense? So it's broadly defined as a clinical syndrome that occurs in children who are less than 2. One of the other things that we're really getting away from is because we said we are making a clinical diagnosis of this, we're trying not to do viral testing, right? We're trying not to do all those x-rays that are out there, and we're keeping up with the data of what is best for these kids with bronchiolitis. And do you guys remember when we had a bronchiolitis scoring system that was here? Not to say that that might not be introduced, but before we would score these kids out and then we would follow a treatment plan, and none of the things that we had on that treatment plan are supported anymore. It's quite bizarre. So if the idea was we would do the viral testing, and then if we found 2 kids that tested with the same sort of viral bug that was in there, we could cohort them into rooms, and then you as the caregiver could just share that room and just be in that one room. But it wasn't really supported. They sort of said those 2 might have that same virus, but they might have some other bacterial situation that was going on, and now they just shared it with each other. So we're not really headed down that road. Bronchiolitis is characterized by upper respiratory system or respiratory symptoms, which is followed then by lower respiratory symptoms, right? This is where you start to hear those wheezes and the crackles. We can break it up into these 3 different groups: mild, moderate, and then severe, right? This is where you start to see that respiratory rate, which is around the 40 range. There's stats possibly are greater than 94% in that area, they're usually feeding normal. The moderate bronchiolitis kids, this is where you start to see that guy, right? So, just so you know, your first line of defense that I always push on people with these kids, especially the ones that you see with moderate bronchiolitis, is Q4 suctioning. Go to town, do it. Please just let the RT know if you just did it so that they're not coming in there and waking them back up a minute later to do it again. One of the things that came out in one of the recent up-to-date articles, especially when we started putting this out there, was that a lapse of more than 2 Q4 suction periods, so 8 hours, kept kids in hospitals 2.5 days longer. So that's a pretty major expense, okay? So I get it. I come upstairs and you're like, Ryan, are you really thinking about waking my kid up? We can discuss it, you know what I mean? But let's just try not to go more than 8 hours. Sound all right? Anyways, these are these kids. That's your first sign. Then jump to other stuff. My frequency is somewhere between 40 to 60. My stats are probably 90 to 93, and that's without oxygen. This is where you're going to start to hear that wheezing. Because they're wheezing doesn't mean that they have the same issues that albuterol is going to treat, okay? We've launched studies trying to treat these bronchiolitis kids with albuterol, and it's not touching it unless there was some other underlying issue. So I get it. It's so easy to be like, do you hear that wheezing? Go get an albuterol nebulizer. But if you go give it and it doesn't do anything, it's probably not going to do anything, and we can then put that on the shelf. Okay. Sorry.
No, you're good.
I get long-winded and Emily comes in and tells me to stop talking all the time. Okay, then we get our severe stuff. This is going to be a bummer. Hopefully we can sort of capture the kids' work of breathing with these high flow bowls, right? This is where you're going to see those respiratory rates that are going to exceed 60 breaths per minute, or SATs are going to be less than 90. We're okay with those guidelines that we had, that we put out to everybody, that said if they're sleeping, I think off the top of my head it says we're okay with a SAT of 88 or something like that. If they're somnolent, nasal flaring, you're going to see all this fun stuff. They're probably, hopefully, going to be stable on this. If they're not, we're going to pick you. This is what that severe bronchiolitis looks like, right? It's that inflammation. This is regular. Then we add that inflammation in the airway. Once that airway is inflamed, now we're going to trap that debris and all those secretions, and then that'll lead to other issues down the line. So on this side, right, this is that bronchiolitis side. See the inflammation in the airway? That's right here. Now those secretions get trapped in there. We're trying not to deep suction these kids as much as possible. A little BBG, a little bit of saline, hopefully everybody's happy. But in this case, if that stuff gets trapped down in there, then we're getting atelectasis. Once those alveoli collapse, right, we don't have an area for CO2 and oxygen to diffuse through, right? So our gas exchange goes to hell. And then that can even lead to this upper airway collapse. So this is where it starts to get a little bit dangerous. The thing about this pole is that flow rate that we're giving can provide some type of distending pressure, and you might not actually realize it at the time, but you're holding those cartilage rings open with that distending pressure, and then we're like, oh, we're good to go. And then we take them off that high flow nasal cannula pole, and then that upper airway wants to flop back down, okay? And that's where you see those tracheal Malaysia kids. It's just something to be aware of. So now, put them on high flow nasal cannula. That heat and humidity optimizes that mucociliary transport system. We start to expel those secretions, because I just told you we're going into their Q4, right? We're suctioning the kid out. So now we can open that area up, reduce the inflammation, pop those alveoli open. Suddenly we don't have a VQ mismatch anymore. Everybody's happy, and hopefully we can go to the PICU. That's the hope. Are there complications with this bad boy? Of course there's complications, but I can tell you they are minimal, right? And we are really starting to look at this, because with bronchiolitis, all these articles have said all those treatments of the past turned out were not that great. We're just bothering the kid more than what we need to, right? So really, high flow is sort of one of those things that has shown its face to not slow down the progression of bronchiolitis, but hopefully just capture them before they escalate any further and need to be intubated, right? So with these complications, we can get abdominal distension, right? We exceeded their minute ventilation. Some of that air is going down into their belly. We might have to pull some of it back out, right? They possibly can aspirate. We looked at those articles a lot before we introduced this. and then 2 of them basically came out and said it was somewhere between 4 and 5% of the kids in those trials, multi-centers, there were 1,000 or a few thousand kids, 4% of them aspirated. Was it the flow rate? Was it the high flow nasal cannula? We can't really tell you. Was it something else? I don't have a good answer for you. Pneumothoraxes are rare. They are rare, okay? There is a lot of studies on CPAP, high flow, all these non-invasive supports. Pneumothoraxes do happen. Is it caused by this? It seems unlikely. One of the other things is nasal breakdown. It's another place for a pressure sore to occur. We just need to stay on top of it and pay attention. What I don't have on here is since I left the military and started working at the hospital, it turns out that waterboarding this population is not okay. Okay, military, they didn't care at the time, so we are not going to waterboard these kids. This setup has rain out. That's the nature of the beast. We can't really help it. Pay attention. If you see water sloshing around in there, you don't necessarily need to give me a call. Just if you can disconnect it really quick, dump that water out of the tubing. Hopefully everybody's good to go. Okay. All right, these are what our current guidelines look like.
There we go. All right.
Okay, so we'll discuss some of the changes from the last time that you guys saw the guidelines. Right off the bat, one of the things that you guys are going to notice is that we changed the flow rates from the previous flow rates, where the 0 to 90-day-old flow rates are going to be start your flow at 8 liters per minute. And then 91 days to 24 months, you're going to start your flow at 10 liters per minute. The caveat to this is that you should never exceed 2 liters per kilo per minute. So let's just say, for example, we have somebody who falls within the 0 to 90 days, and that patient weighed 2.5 kilos. I understand that that's small. You should not be exceeding 5 liters of flow to that patient. The reason being that excessive flow rates, the patient will clamp down against it because they will not be able to fully exhale against those flow rates. One of the other things that you'll notice that's on there is that you have very specific directed mission guidelines that are also part of the protocol, or the guidelines, I should say. So as far as the pull setup, just to briefly run down it, we would have 2 high pressure hoses. One is oxygen and one of them is air. Air being yellow, oxygen being green. Those will go into the blender, and the blender, which is right here, will separate air from oxygen. So you can choose to dial in just 21% FiO2 all the way up to 100. And then out of there, it'll come into a flow meter. That flow meter goes down into a little safety pop-off, which is about 40 centimeters of water pressure that will pop off if it recognizes that we have excessive pressures. And then out of there, it'll come through a heated circuit down into your nasal cannula at the end, and that's where they're going to get all of their flow from. So one of the things that we need to be careful about is that this circuit can rate out a ton of humidity. So pay attention to the fact that water will build up in this area, and if you need to empty that out, you can just simply disconnect it, let it run out of there, and then reconnect the prongs right back to the setup.